we should come to the next speaker. I don't know who will be the next. We expect 2 speakers, but are on the way to come. So I don't know where they are. We're still waiting for them. And one is Professor Dousi from Cape Town, and the other one is Professor Dimitroulas from Thessaloniki, but they are on the way to the flight. So maybe we can discuss a couple of things with Professor Schwitter as he is with us, waiting for the speakers. And in the previous talks, I emphasized the role of 3D reconstruction of the scar. Can you comment a little bit on this and what are the clinical implications of 3D reconstruction? Because we discussed about scleroderma and the ablation of scleroderma, and we mentioned interventional MRI and the potential we may get from 3D reconstruction. So we need your opinion.
Yeah, hello, Sophia. I'm happy to be in the session. I had a little bit of communication connection challenges here, but now I think I'm online and I can see you, Sophia, and so I'm happy to participate now. So I cannot comment too much on the case that you discussed, but I think what would be useful to say is I think that we have these late enhancement techniques. We have a good reproducible tool to see scar and necrosis, and I think the evolution of the case is also very important. So if you may be a little bit concerned that many rheumatological patients would need CMRs, and now I would even suggest that they get follow-up CMRs, but it's often, I think, the evolution over time that helps a lot to decide. And I think this patient, I just got the end of the case presentation, but I think in the last presentation case, you said that the patient she's doing well. I think because she was under treatment and she got intensification of the treatment, and this prevented the progression of disease in the heart, and therefore she's doing well now. So I think it's important to understand if troponins go up, for example, what is the reason for that? Because if it is a myocardial infarction by coronary arteries, the treatment is completely different than if the troponins go up because of myocarditis. So I think it's important then to see what is the reason for troponin elevation, to treat accordingly, and then also, if needed, to follow up. I remember a patient that we had on I think it was dermatomyositis, and she had an infarction like this patient that you presented in the lateral wall. And we discussed with rheumatologists that treatment should be intensified. They were not so sure that there is a very powerful treatment for dermatomyositis, so they were a little bit reluctant to treat. And then we repeated the MR, and then we saw on top of the infarcted area in the lateral wall also pericardial effusion and pericarditis. Then we said that the disease goes on the heart and is progressive. Somehow it should be treated. So they installed a more intensive treatment, and then the pericarditis disappeared with the following MRI, and the pericardial effusion also disappeared over time, and she could go home. She left the hospital. I think in this case we had like signs of a bad evolution. Then treatment was installed, and we could stop a bad evolution, and finally she could go home without any active disease on the heart. And I think that's very nice. This is probably similar what happened in the patient that was presented, that you find the reason and then you treat, and you can prevent further damage on the myocardium.
Yeah. And I think we need somebody who will deal with economics in order to let us know what is the cost of at least 2 CMR that may be used for one patient, and the cost of in-hospital treatment, just to have a comparison, because they always accuse the CMR that it is an expensive modality and all these things. But I believe that if a patient needs to stay in hospital, the cost is rapidly increasing. Can we have a rough comparison?
Oh, we did some economic calculations for detecting ischemia by perfusion MRI. So there we have quite a bit of data. Then there is data from the United States if they do such MRs in the emergency department, and they can avoid hospitalizations because they can discriminate the severe disease cases from not severe cases. They're also cost effective with that. Cost effectiveness study in rheumatology I'm not aware of, but I think it's on the other side quite logical. If you can decrease the hospitalization time, this is very costly. I think you only need to decrease a few days or 1 day or a half a day to compensate for the cost of an MRI. So I think early diagnosis is typically worthwhile to do. And also, it's not only a matter of cost, but if you save myocardium on the long term, you prevent the occurrence of heart failure, you prevent the occurrence of arrhythmias in the scar, you prevent implantation of ICDs, and so on. I think the follow-up costs go up quite high if you don't prevent the progression of disease. So if you can stop the progression of disease, this is, from the point of view of cost, very efficient, but it's not so easy to show that. Yeah, I don't know studies on that for the moment.
Yeah, I mean, what we know, not what we don't know. At least we know that there is a significant difference.
Do we have the other participants in the waiting list for next cases? I don't know.
We have 2 more participants, but they are on the way to the airport, and this is a problem.
Yeah. Okay.
So we expect them. For this reason, I asked you about the 3D reconstruction of the scar. Do you think
reconstruction, 3D reconstruction of the scar? Yeah.
It can improve significantly, at least maybe not the diagnosis, but the treatment, the ablation treatment.
Yeah, I can talk for sure of that. I like this topic quite a bit, and I think there are several methods and strategies to come up with high resolution reconstruction of scar in the myocardium. I think in the past we wanted to know, is there a large or a small infarction in, saying, anterior wall, lateral wall? And if you said, yeah, there is a small infarction in the lateral wall or a big one in the interior, everybody was happy, and we were okay with what we could achieve. Now today, it's over with this simple assessment. I would say we want to see the scar in details. We want to see the scar distribution within the wall, and within the scar, we would like to see channels like these slow conducting channels, because they are the substrate for re-entry tachycardia. And if you want to block by ablations these conducting channels, we want to see them. So there are several ways to go for high resolution scar detection. We are working on a quite nice approach where we start with 2D acquisitions, and then we do a kind of reconstruction to get the super resolution, so that the resolution through plane is higher than the slice thickness. This would allow us also to focus on certain areas of the scar, so we would not need to scan the whole heart at the same high resolution, because then we invest a lot of time to invest into scanning normal parts of the heart. With the 2D approach, we have the ability to focus on the interesting areas of the scar and not of everything. So that would be using the time for the interesting structures and not wasting time for normal myocardium. And but this only makes sense if you can go from 2D slices to very high resolution 3D slices. And there are several techniques to get this super resolution, so that the through plane resolution gets higher than the slice thickness. We are working on that, and we are making progress on that. It's not yet ready for publication per se as technique, but we could analyze such data that we sent to Traya Nova's group in Johns Hopkins, and she did then modeling of the electricity in the myocardium. So she could model a fast excitation of electricity in normal myocardium, no transduction or excitation of any kind in the dense car, and the prolonged slow excitation of gray material, of these gray zones. And with these three types of myocardium, she calculated then the excitation of the whole heart. And this shows then after a few beats, which are modeled in the computer, after a few beats, if there are dangerous channels, they start to provoke reentry tachycardias. Then you see the reentry going on in these models, and this helps you to see channels which support are necessary to have reentry tachycardias. So this is something that is very exciting. I think that we can acquire non-invasively very high-resolution scar geometry, scar structure, non-invasively, then run modeling on these scars that are obtained non-invasively, and so we can see where channels are, and we can simulate the reentries like we see that during an electrophysiological study. So usually in the electrophysiology, they excite the heart from these different points with increasingly aggressive protocols. So they couple extrasystoles, shorter, until they can provoke reentry tachycardia. And you can do exactly the same thing in a modeled heart, which is only in the computer, but not no risk for the patient by inducing tachycardias. So you also run such protocols on the virtual 3D heart. And at a certain point, when you get your protocol more aggressive, at a certain point, you can then provoke these reentry tachycardias, and you see where the channels are. I think that's probably the best way to detect channels. You can detect such channels based completely on anatomy. So you look for channel characteristics, the size of the channel, the diameter of the channel, the type of tissue inside the channel, the length of the channel. All these parameters can decide whether this is a dangerous channel that can provoke reentry tachycardia, stable 1 or not. But with that anatomically based approach, you may miss a few channels which are only functional. And I think if you do the modeling of electrophysiology, you can also detect the purely functional channels. So that would be, I think, like the holy grail for assessment of arrhythmias based on scar imaging, is running models on that can reproduce the electricity, the propagation of excitation in the heart. So we're working on that. It's exciting.
No, I mean, I'm just wondering, there are some commercially available protocols for corridors assessment. Are you aware of this? And do you have some common points with this? I mean, their results are close to your results, or they're completely different?
Yeah, I think I can tell you a little bit what we are doing. I don't know exactly what in other labs are going on, but we are currently collecting anatomic, these maps, these carton maps in patients during electrophysiological studies, and then we match these maps with the channels that we detect on MRI. And with this approach, we want to get the criteria that define dangerous channels versus not dangerous channels, because we see more channels, and probably not all of them will be able to produce stable reentry tachycardias, maybe only 2 or 3 beats, and then the channel blocks. We are not interested in these channels. We want to see the channels that can subtend non-sustained VTs. And the criteria to get these non-sustained VT channels, we are working on that. And at the moment, we are not at the point that we can say we defined all the criteria, so that we know exactly which channels will be the ones that must be ablated. But we are working in this direction. We have criteria for some channels, but not at the discrimination level that we already want to talk about. Yeah, I think we need more hearts. Yeah.
Yeah, it's exciting that there are channels, let's say mute channels, that do not lead to VT.
Yeah, the gold standard are the cartomaps, and then we compare what we see in the cartomaps with the maps that we see derived from MRI, and then we will see the channels that match are the dangerous ones, and then we look for the criteria on MRI which define the dangerous channels. So we're working on that. But we did a study with Johns Hopkins on that, and we could see that if you have a higher spatial resolution, you get you see more of channels that have criteria for being able to produce reentry tachycardias. So you see more channels if the spatial resolution gets up. I think that we know. And for these studies, we did not apply the full version of super resolution reconstruction, but a primary version of that, and we could get much better spatial resolution, but it's not the final step that we want to do. Mm-hmm. But this was published in JACC EP last year. Yeah, there are nice maps where you see in the modeling the excitation. So in this study, Trajanova and her group, they run the simulations to get the electrophysiological excitation of the heart. And if I remember correctly, to get about 4 seconds of excitation, so 2 to 4 excitations, you have to calculate about running the computers for 7 hours. Okay. So it's a quite intensive computational action.
Okay.
So to run different
one of the speakers will not attend because